Let's get started. So I will be discussing pediatric perioperative analgesia and what we call a pain-free promise. But before we begin, I'd like to say that a pain-free promise itself, using that term, is disingenuous. So before we get into the topic and the theory and the matter of it, it's always best to speak to your patients and their family about what is a realistic expectation they can have about pain post-operatively. The minute you cut someone or you have a fall, there is no such thing as zero pain. So similarly to surgery, you cannot have surgery without pain. But yes, it is very important to convince patients, older patients and families that there will be some pain, but we will do everything in our power to deal with it. These are the variety of methods that we're doing. And more often than not, a patient who's prepared for some discomfort post-surgical is usually more satisfied than if you were to promise a patient that, you're going to be completely pain-free. So let's begin. So this is how, let's begin first with the neurophysiology of pain. This is a fairly standard topic that comes up. How is pain transmitted from the periphery to the brain? Before we get into the actual matter of it, let us talk a little bit about what pain is. So pain basically serves a protective function. Just give me a moment. So pain serves a protective function, and it's a little more complex than our other senses like touch, taste, sight, and smell, because while all of these particular senses can be isolated to one part in the brain, pain, however, is sort of modulated and given inputs from multiple areas within the brain. So it is a complex sensation that is carried from the periphery to the center, where it is given value at higher centers. What this basically means is my life experiences, my previous experience with pain, my previous experience with surgery, my allergies, basically me as a person contributes to how I perceive pain. So your perception of pain and my perception of pain will be very different. So the same surgery, same pain, what we think would be the same pain will be perceived very differently by patients. So as I mentioned earlier, unlike eyesight or hearing, there is no single center in the brain for pain. It is perceived via multiple areas, and multiple brain centers contribute to a pain experience. And collectively, all these areas are referred to as the dynamic pain connector. Pain is picked up initially by peripheral nerve endings. Okay, moving on to the actual pathway. So that's a lot of text, but let me simplify it for you a little bit. So pain is initially picked up by free nerve endings that are present in the skin, which are considered nociceptors. Noci and septa, they detect pain. Now, these nociceptors that are present in the skin will be basically, once they are sensitized or once they are activated, they start releasing what we call inflammatory mediators. Okay, these inflammatory mediators are hydrogen ions, potassium ions, histamine, serotonin. Basically, an inflammatory soup is created at the periphery. All right, this is the first stage. This is called peripheral sensitization. So when you have inflammatory mediators, you have attraction of your WBCs, your inflammatory cells as well come in, and you have edema. So when you have an injury, this inflammatory soup is what is responsible for local area tissue swelling and edema. So you now have your peripheral sensitization that has happened here at the skin or at the surface. And it also sets off a chain reaction, or rather a transmission of an impulse along what is known as the first order neuron via using glutamate as a neurotransmitter. Glutamate here is an excitatory neurotransmitter. So we know that in the periphery, you have these nociceptors. So locally, they have created a sort of an inflammatory soup, which is corresponding to your edema, as well as transmitting along the nerve fiber, which reaches your dorsal root ganglion. So the first order neuron is what we call a monopolar neuron, meaning one head, or all neurons have a single head and only a single axon. This axon ends in a nociceptor. So this head of that first afferent sensory neuron, first order neuron, lies in your dorsal root ganglion. From this point, your secondary neuron kicks off. So what happens with your peripheral sensitization? This is responsible for your primary hyperalgesia. So if you've noticed, when you fall down, Yes, of course, there is a cut, there is an area that is primarily injured, which hurts the most, but you will also notice that the area adjacent to the injured area is also painful. This inflammatory soup, of course, does not restrain itself to only the injured area, it just goes adjacent to it as well. This is known as your secondary hyperalgesia. So we've sort of covered what peripheral sensitization is, and we've gone in the pathway of pain transmission up until the dorsal root ganglia. Now, moving on, just give me a second. Yeah. Now we come into second order neurons. Now, this is a little bit complex again. So when we try to break it down, the second order neurons always begin from this point, all right, which is your dorsal root ganglia. There are two types of second order neurons. These are nociceptor specific, which is pretty straightforward. It carries only pain transmission up to the brain. Then you have a second type, which is called your wide dynamic range neurons. Long and short of it is, these are stimulated by type C fibers. Now, type C fibers are responsible for slow pain generation. You have your A delta fibers, which carry your fast pain. The minute you have an incision, it carries through A delta, but the dull, achy pain that persists beyond the duration of actual injury is transmitted by your type C fibers. Now, these type C fibers stimulate or activate the wide dynamic range neurons and cause an increase in the firing of these WDRs to an extent where these WDRs are just sort of firing continuously. This process of creating a continuously firing WDR second order neuron is what is known as spinal wind-up or central sensitization. These are very two key components when it comes to pain pathways. One is the peripheral sensitization, which happens at the skin level. Information is carried from A delta and C through A delta and C fibers from the nociceptors to the dorsal root ganglion. At the dorsal root ganglion, more transmitters are produced, creating a sort of another level of inflammatory soup. But from this level, when the second order neurons are activated, you have something that is set up called a spinal wind-up. So prolonged central sensitization can lead to permanent changes in the CNS. This is where it becomes very important for us to understand. If you do not manage your perioperative pain properly, you can set up for chronic pain postoperatively because of the spinal wind-up system. So what happens when you have spinal wind-up? So you have two sets of neurons, as I mentioned. You have a nociceptor that transmits painful stimuli from the periphery to the dorsal root ganglion. This then goes up the brain and it senses pain. Mechanoreceptors, low threshold mechanoreceptors, so touch and just gentle pressure, which is not painful, is perceived by your low level mechanoreceptors and goes to the DRG and goes to the brain. If you notice, both of them synapse on the dorsal root ganglion. When you have this wind up happening, first of all, your painful stimuli become even more painful, which is known as hyperalgesia. Then you have your regular normal touch and gentle pressure, which would otherwise be non-painful, also being perceived as a painful stimulus. So while peripheral sensitization leads to two, which is primary hyperalgesia and secondary hyperalgesia, that is at the site of injury there is pain, adjacent to the site of injury there is also pain. Your central sensitization causes two things primarily, that is hyperalgesia, that is a reasonably painful stimuli being perceived as more painful, and allodynia, which is a non-painful stimulus being perceived as a painful stimulus. All right. So when we have this combination of central as well as peripheral sensitization, this is what causes your post-injury hypersensitivity state that is responsible for a decreased pain threshold, both at the site of injury and in the surrounding uninjured tissue. This is very important and very key when it comes to understanding how pain is generated. So now that we have come from the periphery to the dorsal root ganglion, now in the dorsal root ganglion, a bunch of things happen. First of all, it receives inputs from descending pathways or inhibitory pathways that from the brain. At the level of the spinal cord, the pain perception is modulated. That is, the inhibitory pathways decrease the excitement perceived by the third order neurons. So we have inhibitory pathways acting on the dorsal root ganglion, secondary neurons also acting on the DRG. And after all of this input has been made in the dorsal root ganglion, ascending spinothalamic, spinoreticular, and spinomesencephalic tracts. These are the three pain-carrying tracts along the lateral part of the spinal cord that carry pain sensation up to the cortex. Okay, this is a lot of words and a lot of terms. I understand. Just understand periphery to